So now we come to our last panel discussion
Mark,
of the afternoon.
I don't know if I have the possibility to tell something.
Alexander, do you want to say something?
No, yes, just to let you know if any country or any of the participants feel that the video that I show you about the need to address the population and the need for them to have access to care, if they want to use it, please let me know. I don't know if you have seen it, but I can show you again even the video. But you can contact contact Mark to have access to that video if you feel that this can be useful for countries.
Okay, thank you. So now we come to our last panel discussion with people from speakers from Ireland and Northern Ireland, UK, and Iceland. The first speaker is Gary O'Dwyer. Gary O'Dwyer is the Chief Executive Officer of the Southwest Hospital Group in Ireland, a big hospital group. And he is also the past president of EHM. Gary, the floor is yours.
Okay, thank you, Chair. First of all, I would like to commend and compliment the organisers of the event. It's been very beneficial, educational, and indeed inspiring. And thank you for the time and trouble to the organisers who made the effort, despite the challenge that we have in these terrible COVID times. So just to say that. In Ireland, I suppose a lot of what has been said by the previous speakers, I'm not going to dwell on, just to acknowledge that there's an awful lot of similarity between what some of the previous speakers would have said and what I'm about to say. So in simple terms, in our country, we've had about 36,000 cases, pushing 37,000 cases. We've had 1,800 people, unfortunately, who died, and that's the national position. We've had particular challenges early on with the supply of PPE, which some of the speakers, and particularly Mark, mentioned from Luxembourg in his presentation, and we have had to undertake similar arrangements to manufacture some PPE here, which I think is important. We were challenged with intensive care beds right across the hospital system. And in our healthcare system in Ireland, we have a system of public hospitals, which I'm responsible for 9 across the southwest. And but there are also some private hospitals, and all of the private hospitals were utilised by the state for the duration of about 4 months. For about 4 months, we had the extra capacity of using private hospitals to support the whole public health system. We also deferred an awful lot of activity, and now we're in recovery mode, and that's proved a challenge because although we did flatten the curve, and I'll speak about that in a minute, there's been some adjustments, and unfortunately the curve is now going the wrong way. We did flatten it, and like other colleagues, not as good as Greece though, we were maintaining good progress, but over the last number of weeks that has changed. We now have a system of part of living with COVID. We have 5 levels in the system. Level 1, and just to give you an example so that you understand, I won't go through all of the levels, but level 5 is lockdown. It's more or less lockdown, which we had for a period of time early on. But level 1, and if we mention, say, for example, weddings, which are very important in Ireland, you would have between 100 and 300 people would attend family weddings. In level 1, in a wedding, it's 100 people. No, yeah, a max of 100 people. In level 2, it's a max of 50. In level 3, if we were in level 3, it's a max of 25. In level 4, it's a max of 6. And in level 5, which is effectively locked down, it's a max of 6. And that'll give you the 5 levels. Then if we go to sporting events, which again is, you know, is common to us all right across Europe. Europeans are fantastic sports enthusiasts. So what we have at the moment in level 1, we have anyone who, an indoor event, it's 100 in level 1, an outdoor event, 200, and in a stadium, it's limited to 500. Now, we're in level 2 in Cork. I cover the south of Ireland, and we're in level 2. So that means that we have the 200 people can go into a stadium, 100 people in an outdoor event, and in an indoor event, 50, correct? Now, Dublin, the city, our capital city, is in level 3 at the moment, which means, you know, effectively most outdoor events and large events, you know, they're not encouraged to take place at all, correct? And, you know, and for example, if you're getting married in Dublin today, in a marriage ceremony, it's a max of 25 people. So just that you be aware of it, they are the 5 levels. This is part of our living with COVID. There's significant emphasis on wearing masks, particularly from level 2 up, but all the time. And we were encouraging a lot of people to work from home. And we're also encouraging people to use telecommunications, particularly video links, telelinks, etc. And they have to make arrangements from a healthcare point of view with their family doctor or with their clinic, or contact the hospital before they attend. Because in the hospitals now, we have a COVID stream of people who are potentially COVID positive or are COVID positive. And then we have a stream of people who are non-COVID. During the earlier surge, we effectively only dealt with emergency cases. All non-elective cases were cancelled, and outpatient departments were cancelled, and dealing with chronic illnesses, which our hospitals in conjunction with community services had to do, were practically non-existent. So we've been in recovery mode since about the end of July into August, and we're trying to catch up, but it is a problem. Some of our screening programs have not been re-established yet, but we hope to have those working in the next number of weeks. A lot of all elective surgery, non-emergency surgery was cancelled, so there have been problems since. There's been particularly big challenges with elderly people who should perhaps have been in hospital or with their doctor in maybe May, June and July. So they're coming into hospital now, and some of them are quite sick, and their length of stay in hospital is increased, and the whole care pathway has changed for them. So that's particularly difficult. So we're dealing with that. We've had to reduce our bed numbers to ensure we had proper spatial distance between the beds in hospitals and the beds in community and elderly care facilities for older people who needed institutionalized care or supervised care. So the number of facilities available, the number of spaces in the facilities available were reduced, have been reduced, in some cases quite substantially. So we have a number of challenges, but our use of technology has worked well. Communication has worked well. I believe our leadership right across the healthcare system has worked really, really well, and we've had outstanding leadership right across both political, medical and managerial, very good leadership right across the system. So we're very well pleased with that. Travel in and out of, we're islanders. In Ireland, we're all islanders here. So we rely on either air travel or sea travel to move from one country to another, as you know, and the air travel has been contained quite a lot. So so the government are encouraging people to stay at home, not to travel. And if you come in from certain countries at the moment, you have to spend 14 days in isolation, and this is supervised isolation in some cases. Most of the other issues that I would mention is staff availability. We have a backlog of activities. We used our private hospitals. A lot of stuff worked very well, particularly our data and technology worked well. And we're into the resumption of services between hospitals and communities at the moment. But most of the other, the virtual clinics worked very well. And we did set up a national COVID tracker, which again worked very well in terms of tracking people, etc. Or if there was a contact, you would be now contact tracing was a challenge. We've recruited a number of staff, and we had to get the military in to support us on contact tracing and also on swabbing for various clinics. And we use sporting facilities to assist us to swab the community or swab people who are recommended to come to clinics. And that has worked very well. But we're recruiting quite a number of people now for contact tracing and to continue on the swabbing program, because an awful lot of our own staff, particularly from community services and elsewhere, were redeployed to support tracing and to support communities in different ways. So we're trying to re-establish our services again. So that's where it is. We are doing a paper up for colleagues on it, which we'll share with you in the coming weeks, which all my colleagues are contributing to. So we will share that with all our colleagues over probably in about 2 to 3 weeks from now. So look, that's it, Chair, for the moment. That's a summary. Most of the other issues, both Ugo and Gogo and Ari have covered, so I'm not going to repeat them, okay? But if there's any questions, I'm happy to take them.
Thank you very much, Gary. So I propose, because we are delayed, that we will ask a question to all the participants at the end after the last speaker. And of course, if people want to ask more questions, as I said, it's possible via the link on your screen or on the email. The next speaker is from Northern Ireland, UK. It's Louise McMahon. Louise McMahon is the Executive Director at the Health and Social Care Board in Northern Ireland. And she's also working very close with EHM. She was also during 4 years the UK representative in the Executive Committee of EAHM. Louise, I don't see you on the screen. Ah, okay. So the floor is yours.
Okay, good afternoon, everyone, and thank you for the invitation. And unfortunately, I would love to be in Troyes and to drink a glass of champagne, but maybe in some years when we are free to travel, we can meet again. So as Mark explained, I'm today in Belfast, Northern Ireland, which is part of the United Kingdom. We have had very similar experiences to much of what has been described, but some little differences. Of course, we're part of the United Kingdom, but there are devolved administrations of Scotland, Wales and Northern Ireland, and we have therefore, we can make our own arrangements with regard to our actions around COVID. Also, very importantly, we are on the same island as Jerry and his colleagues. And as you know, the virus does not respect borders. And that has been an important collaboration issue for us. And of course, quite political, but has worked well for us. So what has been our experience in Northern Ireland? I think it's important to emphasise, and across the United Kingdom, that we have not been overwhelmed. In these two islands, we had, unfortunately for those other countries, we were able to see what was happening in Italy and in Spain. It was on our television screens every night, and that helped, I think, convince the general public, as well as our politicians and other key players, that we needed to take action very quickly. We started our planning very early, back in February, very much led by our Chief Medical Officer. And we therefore, the same as everyone else, we planned on the basis of having very significant additional intensive care capacity, ventilators, skill mix, redeploying staff into support ITU. Of course, as we went through the experience, as people became infected with COVID, our clinicians learned more about treatment, and it became less about ventilation as other methods were used. And very, very quick, dynamic exchange of information between clinicians improved treatment and care. We had other arrangements around the health service. We established vast Nightingale arrangements. You will have seen the big Nightingale Centre in London, which ultimately was not used very much. In Belfast, one of our biggest hospitals became the Nightingale Hospital for Northern Ireland, and that remains protected going into the second wave. Very important for us, particularly in Northern Ireland, is that we have a very well integrated health and social care system. So all of the healthcare system is, it's the NHS, it's all the public system. We also have, in my organisation, we fund and plan and organise all of the hospital and the primary care services. So we were able very quickly to set up COVID centres, a bit like Alessandra described, where general practitioners, family doctors were able to deal with query COVID patients and keep those patients away from emergency departments and from hospital beds where possible. That was extremely valuable. We've also had other opportunities to redeploy. So for example, dentists in the community, they were all closed very early, and some of them we were able to redeploy into the COVID centres or into contact tracing. I'll talk more about that later. Also very importantly, which was very successful, so hospitals, health services were organised very quickly, and that was quite clear. We know what to do in that kind of situation. But during sort of late March, early April, we became very concerned about the care home and nursing home sector. And we saw what had happened in Spain, for example. But we were able to, with collaboration and cooperation, for example, to redeploy specialist infection control nurses and so on into nursing homes to support that. Of course, a lot of money has gone into all of this, even into, as Jerry said, private hospitals to buy up that capacity, to have contingency available, to support private nursing homes with additional staff. As everyone has said, staffing has been a major problem for us. Of course, I've talked about how we've helped create more workforce capacity for ITU, but as staff were perhaps had symptoms and needed to self-isolate, or maybe someone in their household had to self-isolate, that has consistently caused difficulties in staffing. And of course, that problem existed in care home settings too. So we've had to support that with funding also. So where are we today? So as Jerry has described, we have had very stringent restrictions on movement. Only essential workers come in to leave home. Schools have been closed and so on. So there was a lot of relaxation of that over the summer months, according to the R value, as was so well described earlier. And now we have, the schools have reopened, but particularly university students are back, not only studying, but also perhaps enjoying to party, and we're seeing more transmission. Also, the transmission is in households, so individuals are having parties for their granny, for a new birth, and that the most stringent constraint now on movement is within your own household. Only 2 households are allowed to meet, even in the garden or in the park or in a restaurant. So that's very strict just at the moment. So we are, as everyone has described, facing into the second wave, and as Jerry described, also the rebuild of all of the other services which were very significantly turned down during the first wave. That is a really serious issue for us. As Jerry has described, we are concerned about people who perhaps needed to come in and were afraid to come in, didn't want to bother us. So there's a big publicity campaign about that at the moment. But also on an ongoing basis, we have serious challenges with regard to waiting lists, even before COVID. So how we are going to rebuild is taking a lot of our very serious thinking at the moment. But as others have described, one of the big lessons is that we've learned that with clinical leadership, with a lot of interdisciplinary collaboration, change can happen very quickly. We've been very agile, very responsive, and it has been a very safe environment. As others have described, there's been a very significant transformation in the use of online, whether that's patient-doctor consultations and everybody working from home. That there were some constraints on that at the beginning, but we hope that we will be able to continue a lot of that and have those ways of working as a constant way of working. We can see more patients, obviously, not the only way of seeing patients, of course, but we want to keep those lessons that we've learned. So in terms of the one of the things which has characterized our whole approach is that, as I said, the need for interdisciplinary working. So my public health colleagues are in this building. Obviously, we work really closely what's happening with the R rate. How does that then translate? How's that advised to our politicians? Just one point on the politics of it. So we have essentially 4 jurisdictions in the United Kingdom, and we in Northern Ireland share the island with colleagues across the border. We have, medical staff who live on the other side of the border, come into work in hospitals here. So early on, that was really important that the politics could not get in the way of cross-border collaboration, and that has happened very successfully. It's delicate, of course, as is everything. So in conclusion then, our experience has been characterized by collaboration, cooperation. We've had the community and voluntary sector, which we don't often regard as essential to this type of an emergency, but we have had literally, food parcels for people who are shielding, and everyone volunteering. If people were furloughed, paid by the government not to be working, many of those people have volunteered, for example, to deliver medication to people who are not allowed to leave their house and so on. It's a very, very dynamic situation. It's changing day by day, but I'm confident that we will continue to work together and all of the expertise will be deployed to keep our communities safe in going into this winter. Thank you.
Thank you very much, Louise McMahon. Yes, we have a lot of challenges to manage, and do not hesitate to ask questions to Louise McMahon on online and on your screen or email. So now we come to our last speaker. Last speaker is Dr. Pál Matthíasson. He is the CEO of Landspítali. Landspítali is the National University Hospital of Iceland. Pál Matthíasson is also a new member of the EHM Executive Committee representing Iceland since 2020. Please.
Yes, hi. Can you see my slides?
Yes, yes, we can, Pál. Yes, yes, we can.
Okay. That's probably better. Yeah.
Yeah.
Great. Well, it's a big honor to be here with you all guys today, and I've been listening with great concentration on your talks as much as I could, because we are now facing phase 3 of our COVID crisis. So that means that I have to run and deal with that problem from time to time, but I've been able to stay with you through most of today, and it's been really informative. Well, I wanted to tell you a bit about the response of the National Hospital and the health authorities of Iceland. Just first, quickly, Iceland, as you know, it's an island. It's a small population, and these things, of course, affect our response and in some ways make it easier. Although I think, as I will show you, we were able to gain good results, particularly in the first phase, definitely. And that was due to certain factors which have nothing to do with our size or isolation, really. Now, the National Hospital, of which I'm the CEO, is the only tertiary care facility in Iceland. It has 700 beds, around 6,000 staff. And it's clear that we would be a cornerstone of any response to a serious epidemic like COVID. So just to tell you about some of the results that we have, and then I'll go into it in more detail. One of the results was that we used COVID-19 testing really carefully, and we tested a lot of people through partly collaboration with Decode Genetics, which is a sort of a private genetics company in Iceland. We used random testing as well to understand how much of the population was infected. Just the latest results we have are that just under 1% of the population of Iceland is immune to the illness now. If you look at the primary care staff, the likelihood of them being immune, having been infected, is the same as the population generally. But if you look at staff of the hospital, it's only 0.25%, which tells us that actually the knowledge of properly using personal protective equipment, being careful of using it when looking after patients, actually protects you. And not only have we been successful in that, but also our message to our staff that they should be very careful in the community has clearly led to a lower rate of infection amongst staff. Now, our mortality rate in Iceland is thankfully low. Only 10 patients died. The case fatality rate and the infection fatality rate were quite low as well. I would say other issues that are interesting in Iceland are the fact that we had a general public acceptance of the measures that were taken. We were fortunate enough to get away with mild restrictions, meaning that we had to close schools, but only for 6 weeks from mid-March till early May. We did not go into lockdown, but we had a restriction of the size of groups coming together of up to 20. But this was relaxed at the end of May. And at the moment we are at a maximum group size of 200. Just a timeline of events. We got the first case on the 28th of February, but we'd already in January realized that we would be facing, like the rest of the world's healthcare, a challenge. So we've been preparing. Our laboratories had already devised a test that could be used to diagnose COVID-19 or SARS-CoV-2 virus. And things escalated really quickly in Iceland because a lot of the people who brought in the virus were coming from northern Italy and from Austria, from skiing. And these were kind of middle-aged, middle-class people, a lot of them doctors and nurses actually, who came back and brought the infection with them. So we had serious problems. And actually the first cluster of illness we had was around one of our 2 or 3 intensive care units. But we got through that quite quickly. We were able to organize. We were getting overwhelmed around the 20th of March. And that's when we realized that what was going to happen was similar things that we'd seen in Italy, in other parts of the world where actually infected people were flooding hospital corridors. And we had to think really quickly and try and find a way to manage that. And we came up with a solution that was really helpful. And that solution was actually to put all the diagnosis on, make it the responsibility of primary care. But everyone who'd been infected became the responsibility of our COVID-19 outpatients clinic that was managed by the National Hospital. And that meant that everyone who was on the books was called every day, and they had an app as well where they could register their symptoms, so you could actually get more quickly to people who showed serious symptoms. And through this, we were actually able to manage most patients at home in isolation, because most patients actually did not need to come to hospital. But they were called every day and reassured, and they could always get through with their worries. If people needed to be assessed, they were brought by special ambulance to an outpatients clinic we set up with X-ray equipment, etc., all facilities. And only if that assessment proved that people were really seriously unwell, they were brought into the hospital proper, where we had designated wards for patients and also a designated intensive care unit. Now, this COVID-19 outpatients clinic has also proven to be very helpful in following people after the infection, because we found that about a quarter of our patients have had residual symptoms and problems, and that's not necessarily correlated to how unwell people were to begin with. Now, so just to rephrase, the key elements in our response, I think there were 4 points, and in the response that was successful. Firstly, we had a very open, consistent communication from health authorities. So there were daily TV broadcasts. And I think when on the 2nd of April, a quarter of the population watched it at 2 p.m. The people who were kind of always there, they were called the Holy Trinity. So it was the Chief Medical Officer of Iceland, it was the Chief Epidemiologist, who's an infectious disease doctor, and the head of the response team of the police force. There was a 4th wheel, which was myself. I was there every day for weeks on end as well, but only when the epidemic was at its worst. Now, that was 1 point, because I think it was very open communication. People were really open about the unknowns, willing to admit that we might have to change course very rapidly because nobody knew very much. But people actually appreciated that honesty. And it made it far easier because nobody knew anything. So we had to change course quite often. And if you've been open about it from the beginning, then it's really easy to backtrack. But if you've claimed to know everything, then that becomes quite difficult. So that was the first thing. The second thing was extensive testing. So we used collaboration with Decode Genetics, as I said. We used quarantine quite a lot, and I'll come to that a bit on another slide. The third bit was the COVID-19 outpatients clinic, which I mentioned. And the 4th bit, which was quite important, was a centralized stockpile of personal protective equipment. Thankfully, we had stockpiled equipment after some previous pandemics, like the SARS pandemic and the swine flu, etc. And we hadn't thrown it away, even if it was out of date, and it actually was working still. So we had that to begin with, but then the National Hospital was given the responsibility of obtaining a centralized overview of how much PPE there was in the country, with importers, with private institutions, etc. Also ventilators, etc. And then we were given the responsibility of actually finding the delta, what was missing, and being responsible for acquiring what was missing. And that proved to be really important. And I actually had to replace the head of our purchasing office with a senior manager in the hospital who is also a neonatologist. Because actually the decisions you had to make, we had an airplane standing on an airstrip in Shanghai, and the equipment that we were supposed to get, it had been snapped away by someone else, but there was something else available. And you had 5 minutes to make a decision whether we should buy that or not. And, you know, people used to Excel couldn't handle it. So you had to have someone who is able to take quickly difficult decisions based on limited information, like a clinician. You had to put them in charts, and that worked very well. Now, here's just a bit about the testing, tracking, and quarantine. So now, a third of the Icelandic population has been tested for COVID. Thankfully, 57% of those who were diagnosed with COVID after testing were already in quarantine, which is important and shows the importance of tracing infections immediately. Because, I mean, for everyone you catch and put into quarantine who later turns out to be infected, you halve what otherwise will be an explosion. By now, 7.5% of the population has been in quarantine, some more than once. I've only been once in quarantine, but some in my hospital have been twice or 3 times. We've had successful tracking of over 70% of all infections, and we use also DNA analysis of the coronavirus. So, for example, now we have a phase 3 of the epidemic in Iceland, and through collaboration with Decode Genetics, we know that all the infections we have at the moment can be traced to 2 tourists who came into Iceland in August. One was, well, I won't say which countries they are from, but it's that doesn't really matter. But it you know, we can trace it that way even. Now, here's just a bit about the outpatients. So we wanted to provide continuity of care of all COVID patients, and we wanted to treat patients at home when possible, because you have to match the need of the patient to the service he gets. A patient who is not really unwell, even though he's got COVID, has no business being in hospital. It's just going to be bad for him and bad for everyone else there. So you have to be able to triage very early on and match and provide people with support still through telephone or through apps or telemedicine at home, and then bring them in quickly and safely if they need to. So we are triaged now. Like, for example, today I can tell you, because we're in phase 3 now, which came up back in September, that we have 680 people in our COVID outpatients. We discharged 100 earlier today. I can tell you that out of those, 22 are red, which means, sorry, 22 are yellow, which means they are not that well. And 3 are red, which means that they are imminent admissions. And we've admitted 2 people in the last 24 hours. Okay, just going on. This is just to show you that you can see how this is the number of admitted patients at any given time, and they were about 45 at the top of the phase 1. And then now we've had phase 3 very recently, but we already see from our predictions, we've used predictive models which have fitted very well, and we can see that we are already on a gradual decline. So I think we are through the worst there, and we've been able to cope quite well. Just conclusions. 5 points or 4 points really. I think our take-home message would be: 1, it is so important to communicate clearly and openly with the public. It's very important to detect early, quarantine and isolate. It is very important to triage into appropriate services, because that's the only way we can cope. You know, this is such a massive undertaking that you cannot afford to give people any more support than they need. That's the only way you can then cope. and give the people who are really unwell what they need. And number 4, it's so important to keep an adequate stock of PPE and distributing it well. So the conclusion I would say is that politics will definitely not defeat the virus. I think the evidence from around the world has proven that. I think what can help us manage it is to use the best possible information and try to obtain an overview of facts. And then we have to be willing or humble enough to make decisions based on this. Thank you.
Thank you very much, Pál Mathiasson. And you will surely also receive a lot of written questions. Now we have to conclude, but first, because we have not enough time to ask specific questions, we only want to hear from you what are the 2 or 3 very relevant words to consider in relation with COVID crisis. And I start with Ugo Luigi Aparo. I don't know, is he still with us? I think no. So, Gary, please.
Yeah, I suppose there's a couple of things. Vigilance and ensuring that we follow guidelines, because as Pál has very clearly said, it's not going to be politics. It's all of us working together and working to a particular standard, and that is the one way as a community we can defeat this. I mean, it is going to be a significant challenge, but we must follow guidelines, particularly across Europe. We need to all follow guidelines and ensure that we adhere to them. I mean, I think that's the biggest message at this stage, because we don't know where we are on vaccine. Hopefully we will have some breakthrough in the next 6 months to a year or whatever, but we just need to follow the guidelines, both in hospital and in the community. And get the education out.
So long 3 words. Thank you, Gary.
Okay. So, Louise, please.
3 words, please. Thank you so much.
Sorry.
We can try to gather the main ideas. This is why the challenge for us to make it like a resume and like a challenging for the next, and make it easy for the people. This is the challenge. 3 words. Louise?
Yes, I think the solidarity and the collaboration, that we need to respect the different disciplines, you know, medicine, yes, but the most basic support for people. I thought Pál's triage arrangement was absolutely excellent, and we need to continue to engage with our populations to say that we are going to be living with this, and their role is just as important as that of the clinicians and the hospitals and our politicians also.
Thank you.
Pál Mathiasson.
Okay, yeah. I mean, I agree with Jerry and Louise. I mean, I think communication and collaboration, both within the services, but also with the public to get, because they have to be willing to work with us. And then I would say a willingness and humility to face.
I agree
the
with
truth.
that. Yeah, it's a nice word. Exactly, we need this.
Is there anybody other with us? I think the other speakers are no longer on the screen.
I would try to sum up even in French. Yeah, vraiment, on a d'excellents échanges qu'on vient d'avoir toute cet après-midi-là sur les 3 panels, sur lesquels vraiment des expériences des différents pays nous ont permis de voir qu'au final, et je pense que Philippe et Marc pourraient compléter, on a exactement la même convergence, un devoir de réactivité, réflexion rapide, mais aussi comme ça se synthétise sur les 3 mots qui voilà, communication, que les gens puissent collaborer et surtout réfléchir au bien-être de tous. Et ça, plus on communique, et c'est l'affaire de tous ce sujet-là, ce qui rend, on le disait au départ, peut-être des process qui ont l'air simples, même une modélisation simple, mais leur mise en place nécessite la collaboration de tout le monde. Donc, moi, je pense que Philippe pourrait compléter un peu par rapport à ce ressenti-là, mais...
First, I want to thank a lot our European colleague to participate to this debate, and also perhaps one more word, it's anticipation, to try to have every time a time to be in our mind every time a time before the disease. Mais sinon, je suis d'accord tout à fait avec ce qu'ils sont dit. Les mots-clés, c'est communiquer, c'est penser aux autres et c'est travailler ensemble. Et puis, oui, la seule chose que j'ajouterais, c'est l'anticipation. Il faut toujours essayer d'avoir un temps d'avance sur la situation et être capable de prévoir le temps d'après.
Okay, I see Georgia and Laios are also on the screen. And I invite you to say also which are for you the keywords to consider.
3.
Yeah. Okay.
I don't know why 3, because trois in French means 3, but it could be nice to say 3 words.
Georgia?
Well, unfortunately, COVID-19 dramatically unveiled the fragile state of world's health and social systems. My conclusion, my voice is people first.
Yeah, very nice.
I think this is all about.
Okay, thank you.
Laios?
Even in German, you can translate to be easier for him in Deutschland.
We don't hear you. Huh?
Can you hear me now? Hello, can you hear me?
No.
Yeah.
The sound is not good.
It's far. Yeah, it looks.
No, we cannot hear.
Yeah.
We cannot hear.
Can you hear me?
Yes.
Yes.
Much better. Much better. Yes.
Also meine Konklusion ist, dass die Politik, die Wirtschaft, das Gesundheitswesen muss sehr viel aus dieser Pandemie lernen. Die Wege, die verschiedenen Länder gehen, sind dieselben.
The limit of the system.
Laios, sorry, we don't hear you, but you can send us
nice.
your keywords by email, so we will consider them. Thank you.
Okay.
Perfect.
Okay, bye-bye.
Thank you. Thank you once again. It's really a pleasure. I think we are reaching the end of these 2 very nice and intensive exchange moment of 2 days. For this first edition, I would to thank all the participants and attendees from in the place, but also the network. What we can do right now, maybe to have like a conclusion word and ask after all some people to come with us on the stage, please.
Just one quick visit. First, thank you very much for all the organizers, because it was a very, very big challenge to have this conference and a new kind of conference, half in presential, half by video conference, and bravo. So one thing, bravo, of course, I come back to COVID for all the people who in all the country in Europe, of course, but also in everywhere in the world, fight against the disease. And thank you very much for all the participants, all the speakers, because the exchange was very, very interesting. I have a lot of good comeback since the beginning of the conference. So I think it will be a good idea to try to have a new session, a new edition in the future. It's difficult to say no when, because the situation of the COVID and of the capacity of travel and so on is very uncertain, but I think it will be a good idea to have a new edition in a few months. Thank you very much for UTT and IHM and Hôpitaux Champagne Sud, of course.
Yeah, for sure.
Okay, thank you from me too for the invitation first to participate in this very interesting forum. conference, and maybe we have the possibility to organize a next edition together.
It will be a pleasure, really.
It will be a pleasure for us
Yeah.
also. Thank you.
Merci beaucoup, merci à tous. Oui, on peut applaudir, on s'applaudit tous, mais c'est bien. Ce que je me propose de faire, c'est d'inviter Lionel Amodeo, qui a beaucoup travaillé, qui va nous dire un mot. C'est notre il va dire quelque chose en français, et surtout ceux qui sont impliqués pour qu'on puisse prendre une photo avec un mix présentiel et digital, y compris ceux qui ont été en charge de la logistique. S'ils veulent bien se mettre, ça me ferait vraiment plaisir. Monsieur Kérémy, ça serait bien. Ah oui, si on a bien mangé, c'était malheureusement à distance, ils n'ont pas pu apprécier. J'appelle tous ceux qui ont. Voilà, donc c'est ce qu'on avait deviné. Ouais. Et Nathalie, en présidente de l'IPC. Donc là, on faut remettre les masques. C'est ça les limites du système. Je me permets simplement de donner la parole à Lionel 2 petites secondes. Lionel.
Je pense que tu as tout dit. Merci à tous. Merci donc aux partenaires, hein, que ce soit les hôpitaux Champagne-Sud, que ce soit l'Association européenne des directeurs d'hôpitaux et bien entendu l'ensemble de l'UTT, hein, avec toute l'équipe organisatrice. Alors, je ne vais pas me lancer dans les noms parce qu'on en oublie toujours. Et puis, félicitations à Farouk pour avoir décidé de cette belle organisation et puis de son bon déroulement. Et puis donc, à bientôt. Et bien entendu, le dernier mot pour toi, Romain, pour cette communication qui a débuté déjà il y a longtemps. Et puis, je pense qu'il va continuer avec YouTube, avec ce qui reste encore sur le site. Et merci à tous. Et puis, bon retour chez vous. Et puis, be safe.
Thank you all. Congratulations.
Well done. Congratulations to you all. Well done. Well done.